of East Kolkata Doctors Group. And I'd like to welcome Dr. Debasis Datta, Consultant Hepatologist, Fortis Hospital, Kolkata, to our vlog. Now, as we know that this is the Liver Awareness Week, and hence I think it is appropriate that we discuss certain salient aspects of non-alcoholic fatty liver disease, or NAFLD, which is considered as one of the commonest and grossly underdiagnosed metabolic insults. So, Dr. Datta, welcome to our vlog. As a matter of fact, we are both the executive committee members of East Kolkata Doctors Group. Let me start off by asking you a very simple question. How common is NAFLD in the general population? And when we say non-alcoholic fatty liver disease, what exactly do we mean by that term?
So thank you, Samit. I think the answer is very short. Non-alcoholic fatty liver disease is very, very common. Now, there has been studies in India done by Ames and Vellore. Both of them suggest that the incidence of non-alcoholic fatty liver disease in adults in India is around 38 to 40%. But more worryingly, in children, they found that it could be around 35%, which is quite a large number for children. And also, you probably know there is an entity called lean NAFLD, where patients are not obese. The person is also there around 6 to 7%. So the incidence is very high. My guess is this is probably a lot higher in the urban population where we actually work in. So data is still on. And non-alcoholic fatty disease is not just about fat in the liver. It has got implications, which we'll discuss. But it also means that you need to be careful about other organs like cardiometabolic disease. It's not just a fatty liver disease. So I think we'll discuss this as we get along.
Thank you, Dr. Datta. And could you elaborate on the part of, although we say it's non-alcoholic, is it strictly saying that someone is not at all on alcohol, or there are certain limits?
That's not true. There are certain limits to this. So can we have the first two slides? We just have a look at that. So in brief, so if you look at the slide on the left, just when there is fat deposition in the liver, and which occupies at least 5% of the hepatocytes, we call it fatty liver. And the simple steatosis is only presence of fat. When there is inflammation, as I mentioned, three things: ballooning of hepatocytes, Mallory-Hyland bodies, and fibrosis. That means there's inflammation in the liver. Then only we say it's non-alcoholic steatohepatitis or NASH. Now, the terminology is changing these days. It is more or less nowadays, we do call it metabolic associated steatotic liver disease, but that's because there's involvement of other organs also. Second slide, please. So in brief, this is how. So on the left, you can see the normal histology of the liver. When there is fat, you can see this white backgrounds in between. So that's fat accumulation. And when there's inflammation, that is steatohepatitis, when you get more inflammatory cells in the liver. And the last is the fibrosis and the cirrhosis. So there's bridging necrosis and there is complete disruption of the liver. Answering also to your question, Samit, about alcohol, non-alcoholic fatty liver doesn't mean zero alcohol. So the guidelines nowadays is people can have around 140 grams of alcohol a week. So if I may clarify it, 30 grams of alcohol is about 60 ml of whiskey or rum. So a person is probably allowed around 4 to 5 drinks in a week. So that's quite a lot actually. For this is the Western data, and Indian data, I think there'll be probably less. So it's not zero alcohol, but it is actually very limited alcohol intake. We also say it could be NAFLD or MASLD. I hope that answers your question.
Yes, thank you, Dr. Datta. So having established that it's quite a common disorder, I think there's a need to screen for it in the general population, especially those who are at risk. I've seen very frequently that individuals coming with an ultrasound done routinely, or those package tests done, comes with mildly elevated SGOT-PT or maybe a grade 1, grade 2 fatty liver disease mentioned on the ultrasound, get straight away get started treated with medications. do you think we should do something more, a little bit extra to investigate them before labeling them an FLD and starting the management protocol?
You're absolutely right. So if we do ultrasound scan on 10 patients, probably 5 or 6 of them will have fatty liver. So I think this is very important to see whether there's any risk of fatty liver causing liver damage. So all fatty livers won't cause any liver damage, but some of them will. So especially in patients with diabetics or with dyslipidemia and obesity, we should take fatty liver quite seriously, because those patients are more risk of getting chronic liver disease or cirrhosis. However, you can see on the screen, there's a very simple test called FIB4 test. You can do it in your chamber on your app. It's very easy to do. It only includes the patient's age, AST, ALT, and the platelet count. And if the FIB score is less than 1.3, you can more or less be sure the patient hasn't got any significant liver disease. If it is above 2.67, then you are actually going into a territory where patient has got some sort of fibrosis which may lead to cirrhosis. This is an excellent sort of test which was done mainly on viral hepatitis previously, but now we can extrapolate to NAFLD also. Now the problem is the range in between 1.3 to 2.67. What do we do there? I think we need to be quite cautious and investigate these patients and look for who are at high risk. So if you go to the next slide. So if you look at this slide, this is a very old sort of AAC clinical practice data, just modified in 2022. You can see in the middle, the FIB4 index was done. If it is low risk, less than 1.3, you are not very worried. If it's high risk, then you need to be careful and screen for cirrhosis and do the relevant tests. However, if it's intermediate risk, so when you are looking about 1.3 to 2.67, we always these days do a liver stiffness, which we call elastography. And then we determine whether again it's low, intermediate, or high risk. So if it's low risk, if FIB score is 1.3 or so with a fibroscan result less than 7, you are quite okay. You just manage it, weight, diet, and see how it goes, and reach regular follow-up. If it's intermediate, there is a role of treatment, which we will discuss a bit later. And the high-risk ones are, of course, the ones which are going to cirrhosis, and they need to be taken more seriously. So again, this is a very, very practical thing, a FIB4 test, which we can all do to look into it. The next slide, please. So again, if we look at diabetic patients, which I mentioned that the diabetics, dyslipidemic patients are prone to have non-alcoholic fatty liver disease or NASH. On the right, if the ALT and ultrasound are normal, you are probably on a safe ground, unless they have got a very long-standing diabetes with dyslipidemia or very high HbA1c. In these tests, you should look and assess for fibrosis. On the left, if the ALT or ultrasound is abnormal, again, do the same thing what I do before. Do a MR elastography or a transient elastography or fibrosis biomarkers, and assess your patient to see if they're low, high, or medium risk. So it's very important to categorize patients. It's very difficult to do investigations in all patients. But if you do a FIB4 score, or look at the ALT and AST, you can take it further. Next slide, please. So if you look at the fibrosis, now I will ask you to consider the right side of the screen. So once you've done a FIB4 score and you have looked at the transient elastography, you will have several tests. So results. So it can be F0, no fibrosis, F1, F2, F3, or F4, which is cirrhosis. So our aim is to diagnose these patients early, preferably in F0 or F1, definitely not in F4. So we need to diagnose them earlier, F3, F2, F1, or preferably F0, so that we can prevent the progression of the disease. So that's where the importance of FIB4 score comes in, and that's where the importance of doing a transient elastography or MR elastography comes in. So if one has got F0, you are on safer ground. F1 means mild fibrosis. F2 is perisinusoidal and periportal fibrosis. F3, you are going into almost cirrhosis, bridging fibrosis, and F4 is full-blown cirrhosis. So the reason to do all this screening is to diagnose early. Once you have reached cirrhosis, you can't reverse it properly. So we need to diagnose it early when they're in F1, F2, or F3 cirrhosis. Is that okay, Samit?
Yes, thank you. Thank you, Dr. Datta. Now, the thing is, we need a little bit of standardization while investigating and following up our patients. So suppose we write the test, elastography, it gets done in a particular lab. We see when the follow-up is done in another lab, and we find a different methodology is used, a cap may be used, and sometimes it becomes very difficult. So do you think that we need some standardization while doing the screening and follow-up is concerned?
Of course, there's a need for standardization, and I think it's getting done in many places where we'll go back to the slide a bit later, this slide. So standardization is very important. You see, one more thing is, if you are not doing in a proper setup, obese patients need a different probe to look at the elasticity. So it's called an M probe. So in a lot of places where there's no standardization, they will do with the normal probe and you won't get the correct result. So I think going in a good setup where there's expertise to do it should be done, probably at the same place so that things can be repeated at the same machine. In Kolkata, also in India, it's not very common, but MR elastography is something which is also quite relevant and I think can be interpreted quite well by a radiologist. So yes, I agree with you entirely. I think the standardization is very, very important.
Thank you. So having gone through the how common the disease is and the screening process, I think we come to the main part of our presentation, which is the management. So having identified someone with in a NAFLD, we need to manage them. And I'll divide this question in three different parts. First, it's not always about medications. I think to start off, lifestyle modification plays a very important role. The cessation of smoking, moderation, or limitation of alcohol. What is your advice to your patient presenting to NAFLD in your clinic as far as dietary and exercise pattern is concerned?
I think lifestyle modification is the most important thing, as you mentioned. I think from the hepatologist point of view, I think you can talk about diabetic patients, but from the hepatologist point of view, there are very limited medications of limited benefit, and it's only in around F2, F3 stages. So lifestyle is very important. I wanted to show that the next slide, please. So this is an excellent, this is 4 randomized studies, which actually shows what weight loss does with the histological improvement. So these are all biopsy-proven non-alcoholic NASH fatty liver disease patients. So if you look, if someone loses weight of 3%, there is resolution of fat alone in 35 to 100% of patients, different studies. If you lose more than 5%, there's improvement of ballooning and inflammation, close to about 100%. NASH resolution happens in around 60 to 80% of patients if a weight loss is more than 77%. And if the weight loss is more than 10%, there's actual regression of fibrosis in almost half the patients. So this is how important this is. And of course, with that, many studies, many pharmaceutical studies have been done, and everyone stresses the importance of weight loss. And to do weight loss, you have to do exercise and do strict diet. So I personally feel for any patients before prescribing any medication, this is very important, that losing weight by exercise and diet are crucial.
So you just said a while back that NAFLD is probably a part of a spectrum of metabolic disorders. So suppose a patient with only NAFLD being obese or overweight presents to you, should we not screen then for maybe a diabetes or cardiovascular risk factor also?
Absolutely. I would definitely do that. If someone just comes with no previous history, only with a history of what we call non-alcoholic fatty liver disease or MASLD, they should screen not only for diabetes, dyslipidemia, cardiovascular issues, and probably renal issues as well. So I think this is a cardiometabolic disease. So that's what I was saying. The term NAFLD is going these days. Now, it has more or less a new term has come in, which is called MAFLD, which is metabolic associated fatty liver disease. So I think, or someone say MASL, metabolic associated steatotic liver disease. So these terms are coming up to ensure that there is awareness that this is not only a liver disease, it is a cardiometabolic disease, and it affects other important organs also.
Correct. The reason I ask this is because if I divide the pharmacological therapy into two halves, one, the anti-diabetic agents, especially in the backdrop of patients who have type 2 diabetes and NAFLD, and those who do not have diabetes. We have three anti-diabetic agents which have some data, two with biopsy-proven data. One is with pioglitazone, another with the GLP-1 receptor agonist. Just 2 days back with semaglutide, the sole trial from the heart and kidney perspective has come positive. So it's a drug which reduces weight, reduces blood sugar, reduces systolic blood pressure, now is having positive effect on the liver, the kidney, and heart. So probably for us treating diabetic patients, also concomitantly having NAFLD, we have to choose between these three with probably GLP-1 and semaglutide, higher up in the ladder, followed by SGLT2 and pioglitazone. Now, I want to come to you with the non-diabetic agents which can be used for patients who cannot tolerate these anti-hyperglycemic agents or cannot afford, because GLP-1 are very expensive. Yeah. And I want to give pioglitazone, but then the patient can also be given a saroglitazar. So how do you look into this aspect of the choice of drugs in NAFLD?
So the most important thing I would say, Samit, we all need to realize all these drugs work from F1 to F3 fibrosis. So if the patient has got cirrhosis of the liver, none of them actually do very well. So going to the drugs one by one, first, there was a very good study on vitamin E. And I think it was very popular at some stage, but nowadays it has lost popularity because there's possibly an increased risk of ischemic strokes or prosthetic disease. So that's gone more or less. But we still use it, but not for a prolonged duration. Second, there was pioglitazone. But again, as you know better than I do, that it has again lost popularity, maybe because of edema, cardiac issues, and then we had a very useful drug called obeticholic acid. Now, obeticholic acid has been very, very successful in F2, F3 fibrosis. We have used it, and there is regression from F3 to F1 in a lot of patients. However, FDA did not approve it because they were worried about drug-induced liver toxicity. So again, obeticholic acid is less used these days for MASLD. Then is saroglitazar. Now, again, the studies are there, but not great. But again, if you think about it, it only works in probably F2, F3 fibrosis, probably in patients who are obese with high triglyceride levels. So again, the data is not very strong. Now, a new drug which has become very popular, it is a THR beta agonist. Now, this has been approved for the use in NAFLD. The drug is called resmetirom, and it is not still available in India, but many guidelines are now proposing this to use this drug for MASLD. But again, I must reiterate, this is for F2, F3 fibrosis, and they repeatedly said that this drug should be used with diet and exercise. So again, the emphasis of losing weight comes in. So these are the variety of drugs which are available to us, and we use them as and when necessary. But I give a lot of importance, as you just mentioned, to the diabetic medication, because I think it has shown a lot of promise. GLPs, as you mentioned, statins, I think statins are very important also, and the drugs which I mentioned. I think it's a combination of all these three which might be used. We may be able to show the slides, slides 8 or 9, I think.
Yes, please.
Yeah. So this is sort of a pharmacological treatment. So if you have a preclinical disease, what we call non-alcoholic fatty liver, there's no inflammation there. Pre-diabetic patients, so lifestyle modification, as I mentioned, weight loss is very important. Now, when the patient gets NASH with fibrosis, meaning F1 to F3, again, diabetic patients, here we are using the liver-directed pharmacotherapy, which I just mentioned, saroglitazar, obeticholic, vitamin E, and now the new THR agonist. But if there's cirrhosis, things change completely. I think it's actually monitoring and managing the complications like CKD, diabetic complications, and screening for HCC and varices. Next slide, please. This is a very excellent summary which came out in Journal Hepatology. It is from 3 groups: the liver group, the diabetic group, and the study for obesity. So if the patient has got MASH, now they are saying, as I just mentioned, to use resmetirom, which in F2, F3 fibrosis, and if they have got decompensation, to look for HCC. For T2 diabetics, again, what as Dr. Ghosal mentioned, GLPs are choice, possibly SGLT2, possibly a lot of metformin, insulin, statins are very important, and for obesity, again, GLPs are important, and possibly doing some bariatric intervention. I think this is actually a summary of the treatment which we are doing currently, and many studies are on pipeline, and hopefully we will get more results soon.
Right. Just a word on few of our patients being prescribed ursodeoxycholic acid and some combination of amino acids, silymarin, etc. What is your take on those? So
I think I also use ursodeoxycholic acid, actually, but it actually makes me feel better than the patient getting better. Because if you use ursodeoxycholic acid, the liver function test will improve. You will see that the ALT, ST, alkaline phosphatase getting better, but actually there is no improvement in fibrosis. So ursodeoxycholic acid does not improve F2 or F3 fibrosis, but we do use it in patients who have got significant abnormality of their enzymes, because it actually improves the cholestasis and improves the numbers, but it actually does not improve any fibrosis. Again, I'm not a big fan of silymarin. It has been used, very small studies. I again don't think there is any good studies to show that there's an improvement, especially in mast cell patients.
Thank you. So to end, my last question, since we are talking a lot about NAFLD, what are we afraid of if NAFLD is not adequately screened or treated and is allowed to progress?
So as I mentioned to you, if we diagnose it early, we can prevent complications. So what are the complications we are talking about? Cirrhosis of the liver. That's number one from the liver point of view. And from the cirrhosis, people can have HCC, hepatocellular cancer, varices, etc. So to reduce the complications, we are doing it. But as we keep on discussing it, it's not only about the liver. If you have got a patient with NAFLD, you should screen for other diseases, especially diabetes, dyslipidemia, and make sure there is no cardiological or renal issues. So I think it is a spectrum where you need to keep in mind that when one organ is involved, possibly other organs are also getting involved. And by diagnosing early, you can prevent complications and give them a longer life, I would say.
Okay. So to end, one more last question, since we do not have any question in our chat box. Having screened someone for NAFLD, how frequently should we then repeat the screening? Or having diagnosed someone as F0, F1, F2, how frequently should we then repeat the investigations?
I think it depends on the patient profile also. So if someone comes with F0, staying well, I won't repeat it that often, probably do blood test every 6 months or every year. Someone coming with F2, F3 fibrosis, the things are different. I would give him a trial of medication with lifestyle modification and maybe repeat the fibroscanavin in 6 months to a year, depending on what the results are. So if they are F4, then the guidelines are very clear. You do an ultrasound every year to look for any HCC or any early tumor, and you need to do varicose screening every 1 to 2 years. So then you are reaching a stage where the complication has already happened. To prevent it, I would like to see the patient probably twice a year in patients who have got early disease, maybe a bit more frequently if they have got F2 or F3.
Thank you very much for the wonderful and enlightening interaction. I will just end with a few summary points, and if you have something extra to add, please feel free to do so. So NAFLD is a common and potentially dangerous metabolic complication. Screening should be conducted for those who are at risk, mostly those who are overweight or obese, have type 2 diabetes and other metabolic risk factors. As Dr. Datta said, a very simple way of doing it is to do a FIB-4 score and follow it up with some form of elastography. And depending on that, we need to decide whether the patient should be on pharmacological therapy or not. But most important, lifestyle modification. Losing weight is extremely important. And we have molecules which can help from the metabolic profile in the form of weight loss with GLP-1 receptor analogs, SGLT2 inhibitors. And in select patients, we can definitely think of using pioglitazone, vitamin E, obeticholic acid, and saroglitazole, as Dr. Datta just said. Just point of caution, patients on statin and being given saroglitazole, in certain subsection of patients, the creatinine might go up. And as Dr. Datta said, the renal profile should also be, I think, screened for quite on a routine basis. We didn't touch upon, but probably those who are morbidly obese, even bariatric surgery might have a role to help them in the overall metabolic profile. And let's be aware of the fact that if we just let it go and not screen the appropriate population and not try to manage them, these are the patients who are at high risk of cirrhosis of liver and probably even hepatocellular carcinoma in the long run. So that's how I'm going to summarize this particular blog. Any additional message, Dr. Datta, you're free to leave.
I think you have summarized very well, Samit, and I think we should try and follow that. Thank you.
Thank you.